As Gagat already mentioned earlier, this is just the first of our webinars for the UHC lecture series. And thanks, Gagat, for reminding us to be active passengers. I think this is a good way for us to really understand what universal healthcare is and what our responsibilities as Filipinos are, and of course as health practitioners. We would also like to welcome our guests from the Philippine College of Physicians Southern Luzon chapter, Tanawan Medical Society, and the Philippine Medical Association. Okay, and now let me introduce our main speaker. He's a senior vice president from PhilHealth, and he's currently assigned to handle the UHC policy development team. As Gagat also mentioned earlier, he was one of our speakers in the AC Health Leadership Summit earlier this year, and also in our previous Health Leadership Summits. He was also an active speaker in those events. So let's all welcome Dr. Ish Pargas.
Good morning, everyone, and thank you for the invitation. Thank you, Ms. Bengzon, for the welcome, and hi, Nikki. Thank you to Dr. Nazareth for this invitation. Well, I am not an expert, but I was invited, so I will give you the lecture. There were two topics given to me. Can you see me actually? Sorry. There. Can you see me
Yeah,
now?
Doc, we can see you now.
Sorry. Sorry. Okay. So again, I was invited by Dr. Nazareth to provide you a lecture. Technically, she gave me two topics on UHC and of course to zero in on the DRGs, which we are actually preparing for now as part of our mandate under the UHC. So I'd like to share my presentation. It took a while and still for others to achieve the UHC. Some are decades from now, but we are very ambitious on this. Actually, our law provides initial 6 years of an initial implementation. Then after which, after the first 6 years, there will be an independent assessment and evaluation of the initial reforms. And then thereafter, the President of the Republic of the Philippines will issue an executive order upon the positive recommendation, of course, of the assessment and the evaluation if there will be a national implementation of the decided model for the UHC. And technically under the law, that's probably after 6 years, and that's in 2026. Okay, 2020 and 2021, of course, there is the pandemic, and of course, until now, but we pursued and continued, although we backed down a little bit in order for us to respond to the needs of the pandemic. So we start with the principles of the UHC, and technically, it aimed to have an integrated and comprehensive approach to ensure the health literacy and healthy living. And of course, as a mandate would have and should provide a protection from health hazards and risks. Please take note some of the very important phrases like integrated approach, comprehensive one, and take note this is for health literacy and healthy living. So the health promotion in that case and preventive plays a big part in the UHC. And take note this is healthy living, such that this does not only concern health factors, but also other social factors that will contribute to a healthy society. So meron pong mga provisions and sections, even in the law, that would focus on environment and all others, social protection issues and all others that should provide and make the environment able to provide healthy living.
No,
One of the principles really, yes po. One of the principles also is that this approach is a whole of system, whole of government, and whole of society approach. So if you're familiar with the law, you will see that there are a lot of roles and clear delineation of roles, especially from different departments and agencies of the government. But there are also clearly delineated roles coming from different stakeholders. There are roles and responsibilities identified for the society and for a government, because again, the approach really is whole of government and whole of society approach. Now, the whole of system, of course, is that one, this is not just about information technology being interconnected and interoperable, but really all the processes, people that will be part of the system should be involved in this particular health reform system. Okay, but take note of the last phrase in this second principle, especially in the development of health policies. So this is an opportune time, especially for us, because although we have come out with some of the foundational policies for the UHC implementation, still the operational and specific guidelines are still in the pipeline. Some and actually most of are still in the pipeline and in the development. And so this particular activity is very important in order for us to get all your inputs, suggestions, and even comments, and hopefully no violent reactions. But they will that. But the 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 law in itself actually recognizes that in the development of health policies, everyone should be involved. So another principle is that, one, really, there should be a model that can provide a comprehensive health services. That's why even in the benefits that should be provided under the UHC, it would really take a comprehensive outpatient benefit and inpatient one. But at the end of the day, it should provide financial protection to every Filipino. And please take note of the fourth principle, that this is a people-oriented approach. This is not just a patient-centered approach, because this is centered on people's needs and well-being. This is not just for the sick, but also for the well. And so this is really a people-oriented approach. What are some of the objectives that we want to achieve technically with this UHC? The basic and the most important, as actually earlier said by Ms. Menzon, is that everyone, and to make sure that everyone has an equitable access, but not just to healthcare, but really as modified quality and affordable healthcare. And of course, again, as mandated, there is a financial protection against ill health and risks. And again, as part of the objective, this is being progressively realized, no, through the systemic approach and clear delineation of roles. So at the end of the day, all of us should make sure that every Filipino will have an equitable access to quality and affordable healthcare. So how do we do that? So the universal healthcare, really, we will discuss this according to the dimensions as provided by the WHO. And the three dimensions technically are the population coverage, the service coverage, and the financial coverage. Of course, the population coverage, all of these three will have significant reforms under the UHC, some of which are written here, but we will discuss this more extensively later. But these are some of the major ones. And technically, the population coverage would speak of who are actually covered. The service coverage is what are the benefits, and the financial coverage is how deep is the coverage, or how deep is the financial coverage of this, what is the support value. So coming from this cube, if you will see the cube, this is the WHO cube. Currently, we are in the blue one, and what we want to achieve under the UHC is the outside cube, such that the population is expanded, the services is expanded, and we provide more and we cover for more financially. Okay, so next slide. This is the framework of the Uhc Act itself. So these are some of the components, and these are the major provisions and sections. Of course, on the principles of the UHC, there are reforms in the National Health Insurance Program, which is being administered by PhilHealth. Reforms particularly in the health service delivery in the local health system, and to make sure that the reforms in the health system are actually implemented and followed the environment is also able or enabled to support such reforms, such that there are also provisions for human resources for health. There are regulatory processes and systems involved. There is the governance and accountability. So lahat po yan, meron din to make sure again that the environment is enabled to support the reforms that we want in the health system. And of course, to make sure that these reforms are sustainable and attainable, there are appropriations provided. Okay? But syempre, we will monitor and we will still check on this. And since this is a government activity, then there are also penal provisions and other provisions as identified. So we will discuss UHC coverage, again, patterned after the three dimensions: population, service, and financial. We will infuse the discussion on the DRG when we reach the financial coverage, such that the two topics will actually be interrelated. So for the population coverage, in section 5, this is one of those sections which actually will answer to the access. Is that every Filipino shall automatically be included in the National Insurance Program. So technically, prior to the UHC, we are talking of coverage, but right now, because of the UHC, every Filipino is now a member of PhilHealth. So that brings every Filipino already as an automatic or covered under PhilHealth, and that is section 5. So that already provides one of the responses to the access issue. But remember, the access is not just being a member of PhilHealth. There should be facilities and there should be benefits, access to those. So,
Okay,
however, everyone,
sorry. Hello.
yes,
Hi, Doc. Sorry, there's a
yes,
ringing sound lang coming from your audio. Um,
sorry.
there, it's gone.
Sorry,
Thank
I
you.
have a chime in my office kasi. So,
Thank you.
tinatamaan yata na namin. Sorry for that. But,
Thank you.
the law provides that everyone is covered, but we are also provided with responsibilities and accountability such that, again, as one of those whole of government approach and whole of society approach, we also have the responsibility and accountability to be included in the database. So ang tanong natin ngayon is yung lahat ba ng present ngayon or yung lahat ba ng kakilala nyo are actually already registered in the database of PhilHealth. So baka kasi meron pang mga hindi. That is our responsibility. We have to be in the database such that pagdali po, pagka kailangan natin gamitin or wag naman sana, ay tayo madaling makakagamit. So yun po yung isa sa kinakailangan at isa sa responsibility natin. Kasi nga, one of those issues as part of the system, whole of system approach, is that everyone should be interconnected and interoperable using the information technology. And that the IT and the data is very important as part of the health reform system. First, we need the database of every Filipino so that mas madali po ang pagdating sa gamutan, sa treatment of care, and of course, doon po sa ini-issue natin na gustong mabago with regard to referral system. So again, that is a question I pose to everyone. Are you already included in the database? If not, please do so. Under population coverage also, there was a simplified PhilHealth membership. I'm pretty sure all of you are familiar with the previous membership of PhilHealth na napakarami, but right now under the UHC, we only have two. And this is direct contributors and indirect contributors. So most of those sectors that you knew before are actually assigned now either under direct or an indirect contributor. The difference now is just the capacity to pay. For those who have the capacity to pay, they are considered to be direct contributors. And for those who don't have the capacity to pay, they are considered under indirect contributors. So the direct contributors would include those who are employed. Remember, kasambahay. They are actually employed now as provided by their own law. So yung po mga kasambahay natin are employees and you are actually employers. Self-earning individuals, including the professionals like us, doctors who are here, or those in the health workforce. Overseas Filipino workers, and then of course down the line. The indirect contributors would those who are actually have no capacity to pay, and the premium contribution is being paid by or for by the national government. Remember, it is the government who pays for their premium contribution, not the local government anymore. So this will include all those that you know under indigents, those who are in the Pantawid Pamilyang, Filipino, the 4-piece program, of course, the senior citizens as identified, but the senior citizens who are not employed or not employed anymore. PWDs and then the like, and sa Sangguniang Kabataan, the premium contributions are being paid for by the national government as provided by the SK law, of course, only the officials, and of course, the rest of the others who don't have the capacity to pay. So dalawa na lang po yan. So kung mag-uusap po tayo, it's either you're paying your premium or the government is paying for your premiums. Okay? Now, gusto ko lang isiningit ko lang ito because I'm pretty sure it's a hot topic right now, and because you are here wearing different hats. One, you are a member. Second, you are, I'm sure, as an employer because of the QualiMed. Second, you are professionals or service providers, being doctors or the rest of you. And then, of course, the others would fall under different categories. Some of you might be paying for your own premium contributions. So technically, the premium contributions now is provided by law also. And so these are the shifting of the payors. The direct contributors pay for their own premium contributions, and the indirect is being paid by the national government through this collections from sin taxes and then the rest, of course. But remember right now that the premium contributions is based on the floor and on the ceiling. And then the floor is at 10,000 and the premium ceiling is at 50 to 100,000. You will understand this more later in the next slide. And the premium rate is set at 2.75 to 5% as provided in the UHC Act. So this is the premium contribution, especially for those direct contributors. So now we are here, 2022. So if you would see, there is already an announcement that the premium contribution is at 4%. And the income floor would be at 10,000, or the lowest would be at 10,000, and the highest or ceiling would be at 80,000. So if your salary is 10,000 and below, your premium contribution is at 4%. If your salary is 80,000 and above, your premium contribution is computed at 4%. Anything in between 10,000 to 80,000, again, times 4%. So a Senate bill filed by Senate raise poll to suspend. Just like in 2021, when there was pandemic, the 2020 in 2021 premium contribution. 2022, there was already an instruction from Malacanang that we can implement the 4%, and so we did. But there was a move now to suspend. But then this is again mandated by law, so another law is needed to suspend this implementation of the premium contribution. So until 2025, we have the 5%, and again at computation of 10,000 being the floor, at 100,000 being the ceiling. Please take note also that everyone enjoys the access, and that everyone enjoys the immediate eligibility for any program benefits of PhilHealth. However, for the direct contributors, they shall also be required to pay their premium contributions. And the law now provides that there is at least a surcharge or a penalty of 3% for the employers, and of course the others and for the employees, 1.5%. For self-earning individuals. But for those who are employed, it's a 3%, of course, charged to their employers if you are going to have your missed contributions. And this is computed monthly as an interest. Okay? So we need to go now to the coverage, which is also a part of the access and making sure that the service coverage would also provide the quality care. Okay? So you're now, everyone is a member, but first, saan po pwedeng kuhanin yung mga serbisyo? Second, ano yung mga serbisyo na pwedeng makuha bilang a member under the UHC? Okay. So the law provides that every Filipino shall be granted immediate eligibility and access. So you are a member and you are granted immediate eligibility. But of course, being a member, you need to be registered and granted tayo ng immediate eligibility, but the law also provides that we should also be paying our premium contributions with interest at that if you miss. Okay, so those are some of the major provisions too. Now, what are the benefits that we can actually get? The law says that there should be preventive, promotive, curative, rehabilitative, and palliative care that should be provided to every Filipino. So saan po natin makukuha yan? And paano yan ibibigay sa atin? And ano ba ang mga nakapaloob na serbisyo dito? Okay? So first we start with the organization of the local health system. Paano natin at saan natin makukuha ang mga serbisyo na ito? Now, the law provides that the health system now will be reorganized into local health systems. And the local health systems would be organized into a province-wide or a city-wide local health system. Okay? Please take note na medyo qualified po yung citywide. Hindi po ito basta city lang. Those who can actually have a citywide health system are those which are HUCs and ICCs, or the highly urbanized cities and the independent component cities. But if you are a regular type of city, then you are part of the province-wide. But again, if you are HUC or ICC, you can have your own citywide. Okay? So the province-wide and the citywide local health system. And as it is, the province-wide and the citywide health system shall be administered, coordinated, organized, overseen, and with administrative and technical supervision or supervised by a health board. It could be a provincial health board or a city health board. The law also provides that the membership of this board to include the private sector and of course to include other stakeholders, including the indigenous cultural communities or the indigenous peoples. Nasa batas po yan. Okay? So it is a province-wide or a city-wide health system. Okay? Now, these are some of the policies which already are out: the integration, the local health system management tools, and the initial policy on the special health fund. Please take note, though, that most of these policies pertain to the public side or the public sector. In general, the private sector are also included, but the more specific policies for the private sector are still being written now, especially by the Department of Health. Okay? So klarado naman po yun that most of these policies are technically directed towards the public sector, especially on this initial implementation, including the Special Health Fund. So sa Special Health Fund po is with the public sector. Wala po tayo sa private sector na Special Health Fund. It is a pooled fund which later on i-discuss natin under financial protection or financial coverage. So The organization of the local health system, so this is in section 19 and uh, point 12 and point 15, nakasulat din po on how this will be administered, on how this will be supervised, and how this will be organized. So sa gobyerno, magkakaroon po ng mga ganito na reorganization and restructuring to make sure that there are support systems that will technically supervise this local health system. Okay? Now, there is already a policy which came out, which is the integration of the local health system, which is an administrative order 2020-0021. So for those who are actually involved on this, especially those who are also connected with the government, please be guided of this administrative order. But even if we are in the private sector, I guess we should also be guided, and we should also be informed of this, because in general, we can actually pattern our formation later of the network after this. Okay, so there is already a local health system. Then how will services be delivered? Services will be delivered as spoused right now in the UHA through two major service delivery: the population-based and the individual-based health services. The population-based health services are those intended to be received by a population or through an identified specific group of people, no? And of course, again, the outcome is contributed to the general welfare. Okay? So these are some of those responses, for example, to emergencies, disasters. So kung minsan po, ito yung mga examples of which are health promotion, vector control, sanitation, water and sanitation policies. So lahat po yan are population-based. And this will be, of course, spearheaded and financed by the national government through the Department of Health. The other services that should be delivered are called the individual-based services. And the individual-based services are those technically afforded or accorded or can be traced to one recipient or to a person. Okay? So ito po yung mga ambulatory, inpatient care, medicines, laboratories, procedures, confinement for that matter, yun pong mga consultation, check-up, diagnostics, all those which can be directed towards a person are called individual-based healthcare. And dito po, malaki ang magiging role ng PhilHealth sa individual-based health services, because accordingly to the law, the individual-based services should be financed primarily by one, social insurance, which is PhilHealth, and of course, your HMOs and your private health insurance. But of course, majority will be coming from PhilHealth as everyone is a member of PhilHealth. So dito po yung magiging focus also ng PhilHealth, and of course later ang discussion natin sa financial health services. So you have the individual and the population-based services. Now, how will this be delivered? And this is where the healthcare providers will technically come in. So from a provincial setup or a citywide setup, how will the healthcare facilities be organized in a province or in a city? And there is already an administrative order number 19 in 2020 issued by the DOH on the service delivery design. And this is already on the healthcare provider networks. So these healthcare provider networks will be arranged in a citywide or in a province-wide health system. Okay? So please remember that a healthcare provider network is actually a group of primary to tertiary care providers, whether one public or private, or a mix of public and private, but again, offering people-centered and comprehensive care in an integrated, coordinated manner, which now poses primary care, acting as the navigator and coordinator of healthcare within the network. So kung titingnan po ninyo, dito pa lang sa definition ng healthcare provider network, nandito po ang most of the principles na binabanggit po natin kanina, and most of the major reforms in the healthcare service delivery. Very important po ang phrases na group of primary to tertiary care, Second, it's a public or private or mixed. It's people-centered. It's comprehensive. It is an integrated and coordinated. And again, placing primary care as the navigator and the coordinator. So tatandaan po natin yan. So you have the province-wide and the city-wide health system. And within the city-wide and province-wide health system, how are the healthcare providers arranged? So they are arranged into a network, and these are the types of healthcare provider networks as initially identified. There are three: public, private, or mixed. So kung titingnan po natin, the network will be composed of an integrated primary to tertiary care. So kaya po meron kang primary care provider network, secondary care, and the tertiary care. And of course, ganun din sa private, may primary care, may secondary care, and may tertiary care. But this network of healthcare facilities should at the end be connected or referred to an end referral hospital, which we term as an apex hospital. However, the formation of the network would be limited to a primary to tertiary care. So tatandaan po natin yan. So, ibig sabihin, pwede pong mag-form ng network ang public side, but allowed din na mag-form ng network ang private side in a province or in a citywide health system. Pwede ring isa lang or under the mixed public-private. So there should be a contractual agreement or arrangement between the public and the private as one whole network. But they can actually coexist, a public or a private. So when the facilities would form a network within the province or the citywide health system, pwede pong mag-coexist ang public, pwede rin meron ang private, or as one, magkasama po sila. But the more important thing is, of course, kailangan kompleto yung care na naibibigay within those network, within the city or within the province. Okay? So it follows, of course, the components of the healthcare provider network. Diyan po importante nating maintindihan because, again, that would serve now the purpose of the primary care being the initial point of contact and the continuing point of contact, and then placing as the navigator and the coordinator of healthcare in the health system. So dito po tayo naka-red. Ang sinasabi ngayon sa batas is that the primary care is the initial point of consult and the continuing point of consult. And they will also be the one to navigate and coordinate for more care needed by us or by the patient. So in most of the cases, dito po tayo lahat pupunta muna sa ating, except of course as identified the law, seriousness, or when there is a physical impossibility, like you're in another place. Right? Pero yun po ang isa sa reform na gustong mangyari ng system. The system is arranged in a network, and the patients now will shift from a specialist care to more of the primary care, from hospital care to more again of a primary care. Dito muna po tayo. If we need to have a higher or a specialist care, then our primary care will coordinate to a specialist, or if we need to be admitted or confined to the hospital, then again, the primary care is the one who will do the navigation and the coordination for us to be confined into a facility or seen by a specialist within the network of our facilities. So going to level 1, to secondary care, going to tertiary care if that is the needed one, again, within the network of within the facilities in our network. Or later on, if there's a need for us to be seen by an end referral hospital or an apex hospital, then we will be referred. But we are going to be in a network and even the patients will have to go through the treatment of care within the network. And after the episode of care, from the confinement or with the specialist, then they will have to go down because again, it is the primary care who will make sure that we are actually well. Not just going to treat an episode of care, but also making sure that we continue to be well. So kasama po yun sa trabaho ng ating primary care. So from the network of facilities following our patient pathway. Okay? Now, ito po yung binabanggit ko that the primary care now is the initial point of contact and continuing point of contact except in emergency cases. So, kailangan nating tandaan yan because the other provisions would be very dependent on this relationship. Okay? Because, again, ang sinasabi po sa batas ngayon is ang PhilHealth will now endeavor to contract with these networks. So, meron ka ng, everyone is a member, and then meron ka ng, you will get your benefits from this local health system reform, pero yung pong mga facilities na doon now will be arranged into a network of facilities within the public or citywide, within the province or citywide health service. So, paano natin ngayon may enjoy naman yung mga benepisyo na manggagaling sa PhilHealth, particularly on the financial side? Ang sinasabi po sa batas, and this is another reform, is that PhilHealth now will shift to contract with these networks. So that's another reform. We will not anymore do the accreditation when the UHC is fully implemented, but rather we will do contracting. We will not anymore accredit individual facilities, but rather we will contract with network of facilities. Again, for the individual-based health services. And this is under Section 18.2. Okay? So we will now have a contract, at kapag nakontrata na po natin yung mga network of facilities, then basically, makukuha natin yung mga benepisyo, more particularly those provided by PhilHealth. Okay? Okay. Now, ano naman po yung mga magiging proseso under the contracting? There will be, again, in order to make sure that the services being provided are one, quality and affordable, there will be standards, okay, on the network, and there will be stipulations on this and indicators. But the law already has identified some minimum components and minimum requirements for the network contracting. But this is a work in progress. We have identified some criteria already, but we are still identifying more in order to make sure that the affordability and the quality of care are provided by these facilities under the network before we can actually contract with them. So for population-based health services, these are some of the minimum components of a province-wide and citywide health system that should be present. And this will be contracted by the Department of Health. Again, for population-based health services. For the individual-based health services, these are some of those already identified in the IRR as minimum components for the healthcare provider networks prior to us contracting. So kung makikita po ninyo, there is an access to all levels. Again, this answers to the integrated and comprehensive care. There should be a provider payment mechanism that is part of our engagement with PhilHealth. There is a primary care provider, of course, linked to secondary and tertiary care for a comprehensive care and referral. Hold funding, or for the government, it's a special health fund, and of course, patient records management system. This is very important again, gaya ng binanggit kanina, part of the whole of system, interoperability, interconnected, and part of the database. Because ang isa rin natin gusto mangyari natin dito, yung pasyente na nakikita natin on the primary care level, kapag ka po siya in-refer to a secondary care or to a specialist care, yun pong records management, nandun na siya. Hindi na uulitin ang lahat ng patient profile because the records sa primary care ay makikita na or dapat nakikita ng hospital or nakikita ng specialista. So there is already a function or work of interoperability of records management within the network. Okay, patient navigation and coordination system, and of course, legal personality. Some still are, of course, as provided by law, ang lahat po ng healthcare facilities now should be licensed or even accredited by the Department of Health. So kung titingnan po natin, even the primary care are or should now be licensed by the Department of Health, and the primary care professionals will be certified by our Department of Health. And katulad po nito, I think familiar naman kayo being a hospital or healthcare facility or a healthcare professional that with your accreditation, there is still a performance commitment signed by everyone. And so it will be shifted to a performance contract, although we will not accredit individually facilities or professionals, but we will contract with the network. There is a requirement for a performance contract within na kasama sa bawat isa. But again, these are minimum components, and we have so far identified some basic qualification criteria for a healthcare provider network. And this is patterned after the 3 integration criteria or 3 integration areas, like the technical, managerial, and financial. So far, for the technical criteria, we have identified 7 for 4 key features. And these are in addition, of course, to the minimum requirements. For the managerial, there are around 12 under 4 key features. And for the financial, we have around 3 under 2 key features. And this again are still a work in progress. Okay? So, meron ka ng access, meron ka ng reformed local health system, may network of facilities na-engage na sa PhilHealth kasi nakontrata na, ano yung mga benepisyo na makukuha. One of the basic reforms that the law provided is that everyone should be provided with a comprehensive outpatient benefit package. So currently, what we have as a primary care is our consulta, parang 10 diseases lang yata, although it is for everyone, pero limited pa rin yung scope with regards to the benefit coverage. But ang sinasabi ng batas, it should be comprehensive outpatient benefit package. And so PhilHealth is now doing its job, researching and preparing and to come out with a comprehensive outpatient benefits. So what we are looking right now as a comprehensive outpatient is that it should be disease agnostic. So yung pagpunta ng ating mga pasyente doon sa primary care, dapat matitingnan at magagamot at mabibigyan ng gamot at may mga laboratorio. At hindi na mamimili ng mga 10 sakit lamang, kundi lahat ng pagkasakit dapat matitingnan or magagamot or mabibigyan ng gamutan doon sa primary care. At yun ang dinidevelop natin. It should involve services of healthcare professionals. Remember, this is not just doctors, but all other healthcare workers that can provide primary care services. Okay? Diagnostics, laboratories, dental, and other medical services, personal preventive services, drugs, and of course, others services that would be deemed appropriate. So, what are still the other policies in the pipeline? So, hindi lang po naman benepisyo na katulad ng mga packages ang meron sa UHC. There are other policies which we consider too as benefits like, and these will support benefits especially for financial protection. Provided in the list that there is a no-co payment. The no-co co-payment right now is part of the regulations, and this is under the basic or ward accommodation. The law now provides that for every Filipino or for every member who opts to be admitted in the basic or ward accommodation shall be provided with a no co-payment in the government or in the public sector of ward or basic accommodation. For private, it is not less than 10%. And for the specialty facilities or hospitals as identified, it is not less than 70%. And the patient now opts to be admitted in this type of accommodation shall be provided with a no co-payment. This is an expansion of the no balance billing because the no balance billing now is limited to just a several sectors of membership of PhilHealth. But the law for the UHC now provides that every Filipino should be provided with no co-payment. And so it also provides an equitable access billing. There is a governing policy on the diagnosis-related bills, global budget as part of financial protection coverage. Later on, we will be discuss this, the PhilHealth Plus, and of course, the comprehensive outpatient benefit package. More specifically, some of the benefits which are in the pipeline, are provided by UH services as provided by the Mental Health Act, no? And we are providing this in this 2022 as a primary care benefit, but we have designed this, the part of the mental health services, as an integrated approach also, but we will be starting as a primary care benefit. Severe acute malnutrition, rehabilitation medicines in adults, again, as part of the Uhc Act, and of course, as an expansion of our Z benefits for myocardial infarction. But these are just some, because with the infusion of money coming from the PCSO and the PAGCOR, we are going to, of course, expand our benefits to make sure that the benefits they are previously giving are now being covered and expanded by PhilHealth. So you have your benefits, and now, again, as part of the service coverage and as part of the reform, everyone has an access being a member, and also the law provides that everyone is granted immediate eligibility to the health benefit packages. But of course, gusto ko lang ipaalala, there is a need for us to pay our premium, especially for the direct contributors. Okay? So yan po yung mga some of the basic reforms. All our members and everyone has an immediate eligibility. But so yung access ngayon, nakikita natin na sinasagutan through membership and sinasagutan through the presence of healthcare facilities, and sinasagutan din through dapat masagutan din through the affordability issues. Okay, so we will shift now to our discussion to the financial coverage. Okay. Okay. But before that, how can we make sure that every Filipino will now be seen, or will now actually have an access? So the law provides that every Filipino should register daw to a primary care provider na mag-aalaga sa kanila. And this registration is, of course, a personal choice. It's a choice of every Filipino kung saan po sila magpaparegister na primary care provider. And this is guided or with due consideration to proximity, ease of travel, and convenience, of course. So katulad po halimbawa, taga Batangas po ako, but I work now here in Manila, so it would be more convenient for me to be registered in a primary care provider here in Manila, and that my network of facilities will be here in Manila, kasi kung magkakaroon ako ng pagkakasakit, ay dito na ako makakapagpatingin, hindi ko na kailangan umuwi sa Batangas. Or kung kailangan akong alagaan to keep me well, nandito pa rin ako, hindi ko kailangan umuwi sa Batangas. And that is a personal choice. So ganun po yun. So everyone now has to be registered to a primary care provider to make sure na may nag-aalaga po sa atin. So, ang isa sa ina-aspire din ng UHC is that gone would be the days na sinasabi na ang mga Pilipino ay namamatay na hindi man lang nakakakita or nakikita ng isang healthcare worker. Because even the law provides that everyone should be registered to a primary care provider. And of course, this should be facilitated by DOH PhilHealth and the local government. Okay? So, kaya makikita po ninyo doon sa binabanggit natin kanina na the patient pathway follows, of course, again, also the network of facilities such that kung ako ay nakaregister sa healthcare provider na ito in a citywide health system, then kung magkakasakit ako, ito ring primary care provider na to magre-refer sa akin to a secondary care or to a tertiary care dun sa facilities within the network or sa specialista na kinakailangan ako or sa dialysis clinic kung kinakailangan. Again, within or part of the network in a citywide or a province-wide. So, meron ka ng access, meron ka ng network, meron ka ng mga benefits, paano natin masusustain at paano naman natin babayadan ang mga benepisyong ito kasi nakontrata na natin. And this will now be on the financial coverage. Okay? Now the law provides sustainability for the UHC. And ito po yung mga funding kung saan manggagaling ang UHC. But the financial coverage would also include, of course, on how PhilHealth will actually cover for these benefits. Okay? So, ito naman po ay talagang pinanggagalingan na dati pa, incremental sin tax collection, premium contributions, government subsidy, supplemental funding. Pero ang bago po ngayon will be the 50% of the PAGPER funds and 40% of the charity fund of the PCSO. So kung dati po sila ay meron kanilang mga medical fund providing medical services, ngayon po, this money will be infused now to the UHC. So ibig sabihin, yun pong function nila for the medical benefits shall now be absorbed by the UHC. So technically either by the Department of Health, by the local government, or by PhilHealth basically. So yun po mga benefits na binibigay ng PCSO, for example, should now be incorporated to PhilHealth or even that of the PAGPOR. Okay? So, as said, the population-based coverage will be financed basically by the Department of Health from the national government, and the individual-based health services by social health insurance, which is PhilHealth. Andun pa rin po ang private health insurance and the HMOs. Okay? Pero ang sinasabi sa batas ngayon is dapat sa financing ng individual-based health services, it should be complementary. So there should be a complementation between the coverage of PhilHealth and that of the private health insurance and HMOs. There should be duplication with regards to the coverage. Na rin kung kaya meron po na hindi ang kina-cover ng PhilHealth and that of the HMO and the private health insurance. Okay? So through our provider payment mechanism. Okay. So provider payment mechanism, paano natin ngayon
Hello? Hello?
Hi.
I think Doc Ish got disconnected. Doc Ish, are you still there? Hi, Doc Ish. Can you hear us? Hi, Doc Ish. Hello?
Now, can you hear me, please? Hello?
Hi, Doc. We lost you a bit towards the last part of your previous slide.
Yeah, naloko naman ang internet. But can you hear me now?
Yes, we can hear you now.
Okay. So we already have the services. So how do we now pay for those services? And this is through our provider payment mechanism. Okay. The law now says that we should shift to and this is in section 18, that we should now be shifting to another provider payment mechanism as identified. Okay, and this should be this should be a performance event, closed G's or diagnosis related groupings coming from validated costing methods. But there should be no differentiation between facility and professional fees. But again, to make sure that this should provide due consideration to service quality, efficiency, and equity. So yan po yung tinatrabaho natin ngayon. So what is technically a provider payment mechanism? So this will be, the provider payment mechanism is actually provide. This is how much, how often, and what was
Hi, Doc. Hi, Doc Ish. You're choppy lang po. We'll turn off your video first.
yes, please. Thank you. Okay. Okay. So as provided by law, it should be sorry, this is not progressive. This should be prospective payments as being considered under the UHC. So right now we are looking into uh, uh, different types of prospective type of payment mechanism. And this is the global budget and the capitation. I'm pretty sure you are familiar with the capitation because we are already using it right now under the Consult Act. And so when we shift to our comprehensive outpatient benefit package, it will still be using capitation as the provider payment mechanism for that. However, as provided by law, our inpatient now will have to be a DRG based prospective type of payment mechanism. And we are looking now into paying our provider payments through a global budget. All of these are prospective type of payment mechanisms. So in the end, it will be a DRG-based inpatient provider payment mechanism plus the capitation for the primary care. And in total, that will be a global budget that will be provided to our healthcare provider network. Okay? So kung makikita po ninyo, the DRG is also part of a global budget system. Okay. Now, ano po ba ang halaga ng isang provider payment mechanism? For members, it should provide them and make sure that the provider payment mechanism will be used as a leverage to provide quality care. And at the same time, it can ensure financial protection para sa kanila. Ibig sabihin, the provider payment mechanism na ginagawa ng isang insurer can technically cover or provide the financial protection na hinahanap nila. And at the same time, kasama po doon is to make sure that the providers are also actually providing quality care. And of course, for the providers, if they are actually going to provide quality care services, they should be incentivized, or there should be given incentives. And of course, for us, like insurers like us or payers like us, it should be a sustainable mechanism. Now, what would be the goals for a responsive payment scheme? Syempre, efficient use of available resources. Again, it should be sustainable. So at the end of the day, talagang yan naman po ang gusto nating mangyari. Okay? And these payments can actually be in different forms. It could be in the budgets, katulad po nun sa government, or even at the private sector, di ba? You're placing budget or you're putting budgets for the healthcare service. Again, the capitation, the case-based, which we are doing right now, fee-for-service, which we have done before, per diem charges, or even salary, for example, in a government or in a private setup. These are all types of payment mechanism. So in the Philippines, siguro kung familiar kayo, we started siguro the more recent ones, we started with fee-for-service, and then we had a capitation for the primary care outpatient before. Of course, we introduced the case rate, and now we're moving towards a prospective type of payment mechanism, which is the DRG and the global budget as an inclusion. Okay, so shift sa makakatanda in 2011, and then in 2013, it's all case rates. Until now, it is all case rates, but please take note, we have been using case-based payments even before 2011 when we started covering for maternity care packages, for example. They were started with case rates already. Kaya lang nung nag-2011, mas dumami lang. Okay? So, this is again mandated by law under Section 18.3, and even po the DRG or the diagnosis related groupings is already identified in the law. But again, this should be validated through costing methodologies. Now, why change to DRGs? Other than it is alignment in the law, we also have recognized that the shift to a provider payment mechanism is needed because isa po sa mga concerns lagi, especially not just by the doctors, but also by the patients, is really the current case rate is not responsive to the complexity of patients' needs. So halimbawa, na CS, pero yung pala nagda-dialyze din. Or for any types of diseases, may diabetes, may hypertension, may iba-ibang sakit, or matanda na, or complicated ang pagkakasakit or pagkaka-hospital. So there should be flexibility to the differences in the use of resources, especially among service capabilities. So for example, in a level 1 or in a level 3, in a rural, or for example, in a urban setup, in a research and teaching hospital against a general hospital, no? So flexibility to adjustments over time. What about the inflation rates? So yun ba ay naipapasok? Okay? And of course, it should be open to iterations. We recognize these issues, and of course, other than those, alignment with UHC law. So the overall direction really is from ACR to a diagnosis-related groupings, and this DRGs plus the capitation will be paid through the global budget. Now, there are some terminologies to remember because these are important. Baka kasi magkalituhan lang tayo. One is the case mix, and of course, the case-based payment. Remember, DRG is also a case payment. Para lang hindi po tayo malito. Okay? So, case mix is a patient classification. Okay? So, ang case-based naman po is a more extensive case mix because this will involve not only patient classification or disease classification, but also would involve the use of resources. So case payment can be a single flat rate, katulad po ng case rate natin ngayon per case, or can be based on the schedule of payment by diagnosis, which is a DRG. So kung mapapansin nyo, sabihin nyo naman, case rate din naman pala yung DRG eh. So ano magiging diferensya? Okay? So, we now go to the discussion of the DRGs. These are just initial principles on the DRGs para lang maintindihan po natin. The DRG is a system of classification of cases. But these DRGs, these are diagnosis related, or those diagnoses or illnesses with similar clinical characteristics, and putting into are the treatment costs into one group. So same characteristics, same disease types, and clinical homogeneity, the same use of resources. So yan po, di ba sabi ko is case rate also. So each group now will have a fixed payment amount. Case-based pa rin siya, case rate. However, this is further adjustment for each case. Okay? So very important that there is further adjustment doon sa fixed payment amount or the case rates itself. So the history of DRG in the Philippines, this is actually new. I mean, the exercise of DRG is not actually new in the Philippines. I remember we started having the scoping work of DRG sometime in 2000. We actually did a Philippine case-based groups or CBGs to shift to DRGs later on and case mix in 2009. Pero hindi po yan natapos namin yung Philippine CBGs, pero hindi po siya na ipa-implement. We first transition to case rate, but after that, because of the entry of the UHC now, so saka po siya matutuloy. But we have started the study on the DRG sometime in 2000 already. And the Drg Roadmap is actually approved already by the board in 2018, and it was included in the UHC. And just recently po, kung makikita nyo, may lumabas na po na PhilHealth Circular published, I think, last week on the transition of case rates to DRGs for as a payment mechanism for PhilHealth. This is although this is just a governing policy, so but this is already a first step in the adoption of the DRGs for inpatient. Okay. So what is a CBG? It's a case-based group. And again, a DRG is a more complex and more specific form of a CBG. This is a patient classification or disease classification based on several variables, but to define the similar characteristics, but of course, again, aligned with the resource use or the treatment cost. Okay, the DRG is highly dependent also on the use of algorithms. Okay? Ito po yung mga instructions to assign a particular case to a specific group because of these several variables and because there are cost variables also, such that DRG is normally an information technology based system. That's why there is a grouper na ginagamit po para po doon sa pag-group or digitalized case assignments. Kasi nga, this is highly complex. Kaya po yun sa DRG, very important din dito ang information system. Ayaw mag-move. Okay. So again, for the hospitals, this would mean that they can actually relate your patient classification scheme or your diagnosis scheme, patients groups into on how you actually treat using your costs as being incurred by your hospital. So you can actually monitor your quality of care with regard to the utilization or the services that you actually provide with regard to the utilization cost or the reuse of resources. Okay, so it's a class of patient, again, similar conditions with the same resource inputs. Okay, para po sa DRGs, meron po tayong mga different types of DRGs, basic, all patient, refined DRGs, worldwide ang mga ginagamit. Iba-iba lang pong disease classifications. So ano po ang purpose niya? So gaya po na nabanggit ko, this relates hospital case mix to the resource demands and of course on the use. So you can actually monitor on how you actually treat a patient with regard to the use of or utilize your resources to make sure that there is a quality of services being provided. Now, in a DRG, there is a component. There are components and data elements needed. Kaya nga po medyo highly complex din po ito and normally uses an algorithm. Data elements in a DRG. So one of the components of a DRG funding system is the data elements. Okay? So it is highly dependent on codes. Your principal diagnosis, your additional diagnosis, the complications, the comorbidities. These are all coded. Group siya or mag-group siya, dun siya sa tama. So, isa ito sa mga function or trabaho ng doktor. Una, making sure that the diagnoses are correct, complete. Otherwise, hindi po ma-check or hindi makukuha kung kompleto or tama ang mga mababayadang resources or cost of services provided. The length of stay as a data element because it has and will have an effect on the relativity of the cost being used. Admission, the separation dates, the date of birth, because the age is very important, because if you are in extremes of ages, there probably would be more one complication or probably severity of cases. So may mga ganun po. Okay? So these are very important data elements that is a part of a DRG. Also, very important element or component in the DRG are the prices and what are the resources. So PF, how much is the PF? How much or what is the cost of the drugs and medicines? The supplies, the laboratories, even the rooms, everything. That's why health goes through the process of costing. Kaya nga po, doon methodologies. So very important component of a DRG really are the prices and indirect. And what are the costs of this? Because we need those by grouping. Kaya nga po, sabi, especially to facilities,
Okay, I think we lost Doc Ish again. Okay, we lost him completely. Okay, I hope everyone is still okay. It's an hour and a half in the webinar. We will just reach out to Doc Ish to log on. Please send in your questions in the chat box, and then we will raise it later after his presentation.
hello?
Hi, Doc.
Hello?
Hi, Doc. You're
Okay.
back.
Sorry, wala lang ako. So again, it is very important that you actually join this type of activities. So, another component would be the resource intensities. So very important again because gaya ng question na kung case rate din naman pala yung DRG, ano yung better use of that? Well, one, it would provide a more responsive and accurate costing than the case rate because the case rates are just fixed for each ICD-10 and RBS code. But for the DRGs, it will take into account the length of stay, the patient attributes, the diagnosis, and the procedures. So, for example, so the resource intensity, again, the use of the resources for these types or for actually be included or imputed in the computation. So, again, gaya na nabanggit ko, the components of the DRG, very important po yung codes. Okay? Because highly dependent yung ating DRG system to codes kasi nga algorithms yung ginagamit. So, ano po ang mga kailangang i-prepare ng hospital? The hospital, we have the ICD-10 codes right now. So I hope everyone is, and more personnel are actually abreast with the use of ICD-10 codes. Use correctly. So yung pong tama, otherwise kung di ang ating pagkukode, again, hindi naman makukuha kung tama or mailalagay ng tama sa DRG siya. But there is already a movement from ICD-10 code to ICD-11. So everyone has to prepare for that. Second, DRGs would be using procedural codings. Right now, we are using RBS, but we have to shift procedure coding. So, mag-shift din po tayo dyan and everyone else. So, very important po ang codes dito and everyone has to prepare for this. Okay? Again, information management system is very important. Kung makikita po ninyo, this is highly dependent on the systems that will be used. So there is, kaya nga nabanggit ko, there is a grouper software na ginagamit. Okay? So ito naman, nabanggit na natin ito kanina. There should be similar pattern of resource intensity. And of course, from a clinical perspective, it should have the same clinically coherent po yung ating mga magiging pasyente. Okay. So far, this is from a website. Worldwide, this is the top 10 DRGs. No? Normal newborn, vaginal, heart failure, neonatal, angina. So yan naman po ay worldwide distribution. So far yan po yung top 10 DRGs. And paano ba nakukode ang DRG?
Hello. Hi, I think we lost our speaker again. We'll just reach out to him and check if he's able to come back.
So while waiting for Dr. Ish, I'd like to greet the different medical societies present in this session. Of course, the Tanawan Medical Society, led by President Carol Montano. She's also the national president of the Philippine Society of Endocrinology, Diabetes, and Metabolism. We also have PCP Southern Luzon chapter under the leadership of Dr. June Ludovice and immediate past president, Dr. Rodora Valenzona. We also have, of course, the members of the STAMP or the Southern Tagalog Association of Medical Practitioners. Magandang umaga sa inyong lahat. And all these are the members of the Philippine Medical Association. Thank you.
We wanted to apologize to everyone for the internet difficulties of our speaker. Yes, sorry, doc. To the doctors who are messaging, our speaker got disconnected. Due to this, and it's also because it's almost lunchtime. We will be uh continuing this session another time. We have noted all the questions already from the chat box. And we also will advise the rest of our all our participants today when the next session will be to continue Dr. Ish's lecture. Okay, Doc Gina, do you have any final words before we send off our participants from the
Yes,
call?
yes. Oo. So good morning everyone, no? We have learned more about UHC, kaya lang bitin, and we were introduced to the RGs. And sayang wala si Doc Asian, no? Pero I'd like to thank him for a very thorough lecture. So again, thank you to all the participants. And yun nga, the QualiMed Health Network is in support of the efforts to improving access for all, ano, towards the realization of the mandates of the UHC Act. Rest assured that we will continue to provide you with information through webinar series, no? Nabitin tayo, no? Especially the implementation and updates. So once again, good morning and have a safe day ahead. Yeah.
Thank you, Doc Gina. Yes, nabitin po tayo,
Oo,
pero we
bitin nga
hope
eh.
that our attendees can still go in the next sessions, no? This is just the beginning. Marami po tayong kailangan malaman about UHC and also about PhilHealth and DRGs most especially. So I hope that when we invite you again, you're still gonna make time and you're still going to join us for the next sessions. Thank you po ulit.
Thank you, everyone.